Hey everyone, welcome back. I am absolutely thrilled to have you here for part 84 of our CPC exam series. In this explainer, we're diving deep into the tricky world of advanced radiology coding. Make sure to like, share, and subscribe to Decode Healthcare with Harshal. All right, let's get right to it.
So, what are we getting into today? We're going to cover interventional radiology rules, radiation oncology guidelines, nuclear medicine, and radiopharmaceutical supply coding. And definitely stick around, because we're wrapping it all up with a killer radiology cheat sheet to help you crush the exam.
Let's jump right into our first section, interventional radiology and vascular catheterization rules.
When you're dealing with interventional radiology, or IR, coding logic is basically like building a giant puzzle. You're layering the access, the imaging, and the intervention itself. To really conquer these complex CPT blocks on your exam, we're going to use a rule, trap, hack framework. So here's the core vascular rule. The final resting place of your catheter dictates your code, period. If your catheter just hangs out in the main vessel or the aorta, that's what we call non-selective. But the second that catheter takes a turn into a first, second, third, or even higher order branch within a vascular family, boom, you've crossed into selective catheterization. And let me tell you, that changes your code series entirely.
Let's look at how this builds step by step. First, you access the vessel. Easy enough. Next, you might have non-selective placement, like hanging out in the aorta. And finally, you push into selective placement, moving into those first, second, or third order branches of a specific vascular family. Now listen closely. On exam day, do not, under any circumstances, undercode your selectivity. You literally have to track that catheter's exact anatomical roadmap right to its final destination to make sure you're capturing that highest order branch.
Okay, major exam trap alert right here. You absolutely have to know the difference between the surgical catheter placement codes, those are sitting in your 36,000 series, and your radiological supervision and interpretation, or S&I codes, which live in the 70,000 series. The absolute biggest trap you'll face is unbundling. Do not separately code imaging guidance if it's already bundled into the main surgical procedure. It's a classic mistake. So what's the hack? Always check the parent code descriptor for the magic words with imaging guidance. If it's there, you're covered. No double billing.
Moving right along to Section 2, Radiation Oncology Guidelines, spanning codes 77261 to 77799.
For the CPC exam, radiation oncology demands some super rigid, phase-based logic. This sequence is basically your golden ticket. You have to code sequentially, phase by phase. It kicks off with clinical treatment planning. That's your 77261 through 77263 codes for simple, intermediate, or complex planning. From there, you move down the line into medical radiation physics and dosimetry. And finally, you hit treatment delivery. You absolutely cannot jumble these phases up on the exam. It is a strict Step 1, Step 2, Step 3 process.
And that brings us to a massive exam trap you need to watch out for. Actual treatment delivery is reported per fraction or per port, but clinical radiation therapy management, specifically we're talking about code 77427, that is billed in 5-fraction increments. Do not get these two confused. Delivering the daily radiation is completely different from managing a patient's care over a 5-fraction week. Knowing that difference is absolutely crucial for picking the right code.
All right, on to Section 3, Nuclear Medicine and Molecular Imaging.
When we get into nuclear medicine, the whole game hinges on one very simple question. What was the intent? If it's diagnostic imaging, think your bone scans, HITA, or thyroid scans, the code usually bundles the tracer administration and the imaging natively into one single code. But therapeutic nuclear medicine, that involves using unsealed radiopharmaceuticals to actually treat a condition, like targeting thyroid carcinoma. For those, you're going to be looking at the 7905 through 7945 code series.
You really have to bring your A game with specificity here for the exam. You've got to separate highly specific diagnostic scans, like your PETs and SPECts, from those targeted therapeutic tumor treatments we just talked about. So here is your hard and fast rule. Never ever just lump PET, SPECT, and planar imaging into a generic nuclear scan bucket on the test. If you mix up those categories, it will immediately cost you points. Be specific.
Okay, let's shift gears to Section 4, Radiopharmaceutical Supply Coding.
So we've talked about the procedures, but how do we actually code the radioactive supplies and tracers that make these procedures possible? Well, I've got a quick mental hack for you.
Whether you're dealing with diagnostic or therapeutic supplies, you are typically going to build these out using HCPCS Level 2 A codes, like the A9500 series. Keeping that in mind neatly separates the physical supply from the procedure itself. It guarantees your claim is completely accurate and, honestly, it's going to save you so much time hunting through your codebooks.
And here we are at Section 5, the Radiology Cheat Sheet. All right, get your cameras ready and take a screenshot of this high-yield summary. This is pure gold for exam day. Let's do a rapid-fire review. Interventional radiology. Your core rule is tracking that selective order, your trap is unbundling guidance, and your hack is checking that parent code. Next, radiation oncology. Code strictly by phase, watch out for mixing up delivery and management, and remember that 77427 is your 5-fraction management code. Lastly, nuclear medicine. Intent completely drives your code, don't use generic terms, and always grab those A codes for your supplies.
To wrap things up today, I want to leave you with this thought. In the world of radiology coding, a single tiny word like contrast changes absolutely everything about the code you select. It's wild. Are you ready to see exactly how that plays out? Join me next time for Part 85. We are hosting a masterclass full of high-yield case studies and complex interventional dissections. Keep studying hard, you've got this, and I will see you in the next explainer.